Hello. Good morning, everyone. I know there was people in the waiting room and they're coming in, so welcome to everybody. I'll give it just one more second to let everyone join. Wow. Okay. Uh, okay, so we're going to begin. Good morning. Yesterday we began the 2026 Spring Graduate Colloquium, where the Aspen and USU doctoral students have the opportunity to showcase their hard work in research and projects to our academic community. We look forward to a more robust discussion as we support the next generation of scholars. Day two of our colloquium begins with Dr. Caitlin Bruce, who will be presenting on her project related to standardized coloscopy. Sorry, can't say that. We were going back and forth. Procedure in cervical cancer diagnosis. Welcome, Dr. Bruce.
Hello, thank you so much. And colposcopy.
Yes.
So I thank you so much for that introduction. I'm so excited to be here to talk about my project. This is something I'm really passionate about, women's health in general. And so very happy to be here. So my project is standardizing colposcopy procedures, enhancing documentation for cervical cancer diagnosis. Excuse me. I'm a graduate of United States University from the College of Nursing and Health Sciences. So just a little bit about me. I've been a nurse practitioner for about 7 years, registered nurse for about 13 years. I currently work at Kahuku Medical Center. I actually opened up the women's health clinic here in the North Shore of Oahu, at the very tip top of the island. So if you ever come to the island, please come say hi. But they are a primary care clinic that are trying to transition into a multidisciplinary clinic. And we're attached to the only hospital that is within 60 minutes, no traffic, within 60 minutes either direction. So very important place to be to provide medical care. I am also faculty with United States University, and being a graduate of them, it's an honor to be faculty with them as well. I lead the FNP 594 course, that clinical course, so that's a lot of fun. Um, I have specialized in women's health for, I say 13 plus years because that's beyond my practice as an RN. But that's only because I have always been involved in women's health in one way or another. Um, just most notably, I also work with organizations to fight human trafficking internationally as well as locally. So that's just something that is on my heart and has always been on my heart. So exciting news about this project. I was able to present as a poster presenter at the conference for the National Association of Nurse Practitioners in Women's Health, shortened to NPWH, in October of 2025. So that was really great. There were thousands of attendees that I was able to talk to a very large number of them about my project, kind of get them excited about doing something like this in their own practice, and just talking about how it impacted my practice. And this is something that I really haven't talked about much, only because I'm in the draft stage. But I am working on my draft for publication, so with the journal with NPWH. So I am in talks with the editors and just everybody involved in all of that. So hopefully I'll have some good news here coming up in the next couple months. Outside of my professional realm, I am married. We've been married for about 2.5 years. We do have lots of fur babies who are very energetic, and some are cuddly, but most are very energetic and crazy. As I mentioned, we are in Hawaii. We're originally from California, and we moved here to this beautiful state. I came early last year, and he came just a little bit before me. Outside of that, we love to explore the islands when we can. I'm sure you can all appreciate a very busy professional life, so very little free time. But when we do have free time, we do love to explore and just kind of be tourists in the area. I am also a singer. I love to sing. I'm in a community choir worship team at church, worship team for a Bible study. And I just re-entered the world of musical theater in my not so free time. So if you're on the island in June, please come see us. I can tell you more about that. All right. So I'm just going to kind of jump right into it. I'm going to read this first bullet point to you and then just kind of explain everything else. This was my PICO. So this was my question for the project. In adult women attending a women's health clinic in San Diego, what is the effect of implementing a colposcopy quality indicators program with standard operating procedures on the documented rate of critical colposcopy measures and the timely scheduling of women with suspected cancer or precancer compared to non-standardized practice? So as you can see, this project was done in a clinic in San Diego, very high volume. Depending on how many providers were working that day, we'd see anywhere from 100 to 250 patients per day. And the majority, it was OBGYN, so we were doing PAPs all day long, which led to multiple colposcopies. Um, ASCCP, which is the American Society of Colposcopy and Cervical Pathology, they actually have extensive research, and they are the society that gives us the guidelines and the recommendations for colposcopies and doing PAPs and things like that, and anything related to cervical health. They have released guidelines many, many years ago and updated over the years, but they released this template for documentation purposes that includes all of the important elements that we would need to know in assessment form and everything else. So if I documented something and then another provider needed to do a colposcopy on them, they can look back at my documentation and see if there are any significant changes, right? That's why we do this documentation. However, in my literature review, I noticed that the terminology that was being used in documentation was not standardized according to what was recommended by ASCCP, which led to that documentation being very unclear, very questionable, which delayed a lot of care and treatment for the patients. So this is part of the reason why they're encouraging those templates so that we can standardize all of that. Also within my literature review, and I was really surprised about this, maybe because I'm in the realm of women's health, so I talk about it all of the time. But I was surprised to see that there's a high percentage of women who don't understand what human papillomavirus or HPV is. They don't understand that it's sexually transmitted. They don't know that it can cause cancer. It's just this kind of big unknown of, well, I had an abnormal result, but I don't really know what it was, right? That's kind of concerning. So when you're doing something, a procedure like this, especially in a very vulnerable population, you could potentially cause a lot of trauma because these patients don't understand why we're doing what we're doing. So for those, let me backtrack just a minute. For those that maybe are not in women's health or maybe have not performed colposcopy, the official term is colposcopy with biopsy. I lovingly refer to it as colpal or colposcopy alone, but when I do say that, I am referring to the entire procedure itself. Colposcopy is like any scope. You take a scope and you take a look at the cervix. With biopsy, self-explanatory, but basically it's the act of I'm looking at the cervix using acetic acid and Lugol's to see if there's anything showing that I would need to biopsy, and then that biopsy portion comes out of it. I also perform, no matter what, what's called an ECC or an endocervical curettage. That is internally in the cervix, the portion that we can't visualize, where we scrape kind of the cervical canal and grab the tissue that way as well. So regardless of what I see on the outside of the cervix, I do that ECC, and this is something I explain to the patients as well. So this whole project came about because my office was actually really great overall at making sure guidelines and recommendations were in play, right? And that we're using evidence-based research. But I did notice more often than not that the documentation aspect was not necessarily up to par or something that was appropriate. So I decided to create this template. We did have a template there that had some of the elements. And I decided to create a template that filled out the rest of the elements that were needed for documentation purposes. And I'll show you an example of that in a minute. And in addition to this, I also saw that, like I have here, patient education was severely lacking. So if we're moving forward with all of this and we're documenting that this is what the cervix looks like and this is what we're doing for the procedure, we should also be documenting that we spoke to the patients and that we educated them on what we're doing, why we're doing this, the HPV and any other abnormal results. We need to make sure that we're documenting all of that. So I added that into the documentation template as well. And then one more thing that I actually didn't note here on this slide, but one more thing that I noticed was that women weren't coming in for the procedures. I've heard this firsthand from patients who have had abnormal PAPs in the past. And I also read it in the literature that women were not following up as appropriate. And part of that was that education aspect that we noticed the patients did not understand and did not have that urgency to follow up. So they just never did. Sometimes it was a matter of the office never scheduled or never reached out. And so the patients thought, well, no news is good news, right? And then, of course, it might have been scheduling issues and a myriad of other things. But that was one of the things that I noticed, that if we could get the patients in to educate them and then to perform the procedure, that we would be able to document all of this very clearly for the next provider whenever they would have to have this done again or when they had their PAP done. So the third thing that I looked at was that scheduling aspect and getting the patient in within 2 weeks of having the abnormal result. So my inclusion criteria for these patients, 21 years or older, and that is per ASCCP. We start PAPs at 21 years of age. That might change in the future. And so if that changes, then obviously my project can change. But since we already did this, 21 was the age that I looked at. The other criteria I looked at, obviously a woman with a cervix. Vaginal colposcopies are a thing and we do them, but it's a very different procedure. Treatment is very different. And so I just limited to a woman with a cervix. Additionally, I looked at abnormal PAP results, postcoital bleeding, and lesion. So interestingly, before I implemented my project, I was seeing all of those on a regular basis. When I implemented my project, I only saw patients with an abnormal result. So I would have included all of those had they come to the clinic or had we seen them. But for the purpose of the time frame that we had, I only saw abnormal result, which is totally fine. So this is kind of the design that I used. I created a template on Excel, and you'll see down here at the bottom of the screen. This is just an example, fake MR numbers, just because I am using this to showcase. So I had the list of the patients, the age, obviously, because that was part of the inclusion criteria, the PAP date, when did they have it, and when did we receive the result? And then this is where it got interesting. When did we schedule the patient? So you'll see this first one had a consultation about a month out, and the second one did not have a consultation. That might have been that the patient declined it. Maybe they've had colposcopies in the past. Maybe she just said, you know, let's just go in and we'll just do the procedure. I don't need to talk about it, whatever it was. But this one, month out, this one didn't have it. So I look at the colposcopy date, obviously not scheduled within 2 weeks. Now, I'm going to show you this in just one of the next slides, but an abnormal PAP handout. I created a handout to educate the patients on what we were talking about when we did that consultation before the procedure itself. So did we give that handout to the patient? Yes or no? And then the rest of them are these quality indicators that are on the ASCCP template that they recommend that we have in our documentation. So are we documenting the consent, the timeout, the assessment of the cervix, and so on? Losing my mouse here. There we go. So the first intervention that I brought in was the template, the documentation template. And part of why I have a lot of these filled out, you'll see a lot of the boxes are filled out already, was for ease of documentation because a lot of them were new. They were not on the previous template. And so I did get a lot of pushback from providers that they didn't want that extra documentation, right? They would only really move forward with this if it was something that was not going to add extra time. So for the purpose of this, I pre-filled a lot of the boxes. They are all drop-down menus. So if one of these are not correct, they can fix it. But at the very least, this is a typical colposcopy documentation template. And so you'll see that, we did perform the timeout, and then we go through the procedure itself, what we visualize. Here, you're looking at different aspects of the assessment portion, which are kind of all lumped into assessment. But one that stands out obviously is lesion. And then our impression here, they will have to do a drop-down menu for that one, looking as low grade, high grade, benign, cancerous, whatever we see, right? It's very important that we are also documenting if a biopsy was performed, where did we perform it? So looking at the cervix like a clock, we're doing, 12 and 3 o'clock, we did biopsies or something like that. So that's the template that I implemented. And then this is my abnormal PAP handout. So I developed this because I would talk to so many patients about these abnormal results. And if you look at all of these letters and words and everything else, it's kind of like French for those that are not maybe not in the medical field, and it can be very confusing. So I'm a very visual learner, so I like to write everything out. So here we see step 1, you had your PAP. Here are some, not all encompassing, but some of the abnormal results. And this is why we're here talking, right? Because you had an abnormal. I like to circle, I draw arrows, I write all over this, write notes for the patient so that they can take home and kind of digest. After the PAP, if we're having this conversation, the next step would be that colposcopy with biopsy. And I explained to them all of the potential results. Again, this is not all encompassing, but this is what we typically see. And I intentionally drew a line here because negative, obviously that's what we want, but CIN1 is technically precancerous. And your body can actually reverse that still. It is still possible to transition into CIN2, but your body can reverse that CIN1 level. And so if they're above the line, we go back and we do the PAP. If we are below the line, that is more serious, and we transition to step 3. Now, me as a nurse practitioner, I do not, at my previous office, I did perform LEAPs, but I no longer perform them here at this clinic that we have. So I just basically explained to them very briefly what those procedures, what those letters mean, essentially, and just kind of say, we're not going to talk about this in depth. I don't need you to worry about this right now because we're just on step 2, but I want you to see that there is a pathway that if you are below this line, this is where we go, and then we can talk more in depth later. So I have some other notes and things that I write on here, supplements and healthy living suggestions and things like that to help fight HPV and to help boost the immune system. But that wasn't the purpose of what we're doing for my project. So I did not include that on this slide. So my design, kind of going back into that, I collected data over 8 weeks. I created this template or this spreadsheet where I had a page for pre-implementation and post-implementation. And this example here is the same one that I showed you previously. And so this is pre-implementation. an example of pre-implementation. And so we're seeing that, you're scheduling consultations a month out. We want to get it within 2 weeks. I always like to say this anytime I talk about this project, but patient information was de-identified. So I protect my patients at all costs and make sure that there's nothing there that you can say, oh, that's so-and-so, right? So always want to make sure I have that in all of my presentations. My goal was to look at about 164 charts total. So it'd be half pre and half post. And had I done this project even just 3 months earlier, I would have been very close to that goal within that 8 weeks. But as you know, in healthcare, everything ebbs and flows. And so when I was doing my implementation phase, we actually had a decrease of how many patients we had. So I did 26 pre and 26 post. We did 26 colposcopies during that 8-week period. So how I did this statistically is I used chi-square tests of independence that showed where there were specific changes. I also ran an independent t-test, and it did show that this project overall was statistically significant. Now, you'll see in the next slides that there actually wasn't a lot of change in certain aspects, but the change was enough that we see that the project was significant and that it did make a positive change. So this is one of the charts that I was using for all of the critical indicators from ASCCP. So these are all the ones that they recommend down here. And then, of course, did we give that abnormal pap handout to showcase that we did that patient education? Did we schedule within 2 weeks? Did they have that consultation? So I added those 3 in right there. You'll see that there's about 5 that had no change, which is good because that means that we were documenting appropriately before and we're documenting appropriately after for most of them, not so much for, we're not doing the consult. But there's a couple that we weren't documenting on at all, which were the timeout and the impressions. So we had a huge increase of that, which is great. And then there's a couple that actually surprised me when I did my data collection that decreased. Something that we were doing really well with decreased over time. So that was a really interesting finding for all of that. And then here is looking specifically at scheduling within 2 weeks. Again, you're not going to see much change here. Now, these were 52 completely different patients. They were not the same pre and post. So very different scheduling and very different scenarios, right, of why they might not have scheduled. But pre-test, so pre-implementation, we saw 5 patients were scheduled out of the 26, whereas post-test, we saw 6. So there was an increase there, just ever so slightly, but 6 that were scheduled. And then the consultation that were scheduled. So the majority of the patients were scheduled versus the ones that were not, or that had the consultations. But you'll see this is exactly the same pre and post. So we had 19 scheduled pre-implementation and 19 post, again, completely different patients. It was interesting to see the consistency. And again, there's a lot of factors that come into this one as far as provider availability, patient availability, patients declining because they've been through this before or, whatever it was. So just kind of looking at all of these, the project itself was significant, but we found more growth opportunities than anything else. And this office, like I said, is really great at using evidence-based practice in everything that we do. And documentation-wise, really was not terrible, for lack of a better word. But we did see some areas for growth and areas to remain consistent. where we saw the declines in the documentation portion. So really now I'm no longer at this office, and I did kind of give this to a couple of the providers that are still there, kind of handing off the baton, so to speak, and saying, I'd love to see you continue this, and making sure that the template is up to date per ASCCP recommendations. And the project itself, in the proposal, we were looking at sustainability. And so the sustainability of this is that we need somebody to kind of take the reins to make sure that we are up to date with what the recommendations and the guidelines are saying. So I've been in contact with them, and no changes yet, but they have seen slight improvements in scheduling and getting those patients in for the consultation, being able to educate those patients. They are seeing more urgency, which is really great long term. Uh, so it's interesting, and I'm really excited for this kind of as a future exploration. I'm really excited to be able to use what I did in this project in a completely different clinic and put that into the clinic that I'm building right now. And my goal is to well, not kind of, my goal is to set the standard. And this is the standard that we're going through. This is how we will be documenting. This is the process as far as scheduling patients, so that we just right off the bat, we're not having to make a lot of changes and convince providers that this is a good way to do this per the literature that we're reviewing, or things like that. So I'm really excited that we're able to put this project into action and further see how it's going to impact the patient. Um, something that I meant to mention earlier, the reason why we do these procedures, colposcopy, is because we're obviously looking for cervical cancer. Cervical cancer is very silent until it's far progressed. And by that time, you're looking at other areas that might be impacted by this. You're looking at vaginal tissue, vulvar tissue, the uterus, potentially even the ovaries, and just there are studies that show that it can spread to colon. I mean, it can go anywhere. So if we're not consistently doing these PAPs on the patients, number one, then we're missing that opportunity. Cervical cancer is not necessarily one of the top cancers in women. It's not even in the top 5, but it's one of the most easily detected because we have this PAP test that we can do. And of course, standards go by guideline. You can do it every year if necessary, all the way up to every 3 to 5 years, depending on a ton of factors, age, medical history, things like that. But if we're not doing that, then we're not finding the potential abnormalities. So that's step one, is just making sure we're doing those PAPs. But by completing those PAPs, we then transition into doing the colposcopy with biopsy. And we're able to find at the cellular level what that tissue is telling us is going on. And that changes our plan of care. And the whole reason why we're doing this, the push for this clear documentation, is because we need to make sure that it's not a matter of we document cervix, cervix looks normal, and then a year from that, all of a sudden there are lesions all over, it's bleeding, and it looks potentially cancerous, right? So we need to be able to draw a timeline if possible. And of course, that comes with patients also being compliant with that and agreeing to come in. And so that's a huge aspect to it. But making sure that when we are performing these procedures and we're doing the PAPs or the colposcopies, that we're documenting very, very clearly so that we can track where we're at and what we're doing. So I could talk about that kind of all day long, but I just to kind of review that in this project in particular, the 3 goals: schedule within 2 weeks of receiving the abnormal result, patient education, so scheduling that consultation, discussing the abnormal result, and then using that template in completion. And one of those three goals were met. And it was the documentation portion of the template that the goal was met. And so I'm really happy about that. The other two were more scheduling and the education portion. We have a ways to go with that, and that's okay. That's why we do these projects. And I always like to encourage anyone who's never done a project like this before, or maybe just starting one, or maybe you've done a million of them, that when you see that you don't reach your goals, it kind of makes you feel a certain way, but it's a growth opportunity and it's never a failure. And so that's what I look at, is that we met one of the goals, and I'm very happy about that, because that is the most important aspect, is that to help impact the patient outcomes, right? So we met one. Now let's work on the other two. Let's continue meeting this one. Let's work on the other two. So future wise, I'd love to be able to hear and see the data from that office, see how it's changed just outside of that 8-week time frame. See if they are really getting more patients scheduled appropriately time-wise and for consultations. Do the patients really understand what we're doing and why we're doing it? And I'm excited to be able to take that project that I did and mold it for my current clinic. So lots of opportunities here for growth, lots of things to celebrate. But I'm just so excited to have been able to do this project. And I spoke a little bit fast this time, so I am finishing up, but I would love any questions or comments or anything that you have for me.
Thank you, Caitlin. So I have a quick question. At the clinic, was there one person that was responsible for scheduling, or was it like a team of people? And do you think that that makes any difference?
That's a great question. So we had three people on phones. Excuse me, four, because we had two clinics. We had four people on phones that were scheduling. So all of them, we did have meetings throughout this. Before I even started to implement in that 8-week time frame, we had a lot of meetings of this is what's coming, and then during we had weekly meetings to discuss it, to make sure that we were all on the same page, and that they were scheduling within that 2 weeks, and that any questions I could answer. So we did have multiple, so a lot of hands in the cookie jar, but constantly meeting with them to make sure that they were trying to meet that standard.
Thank you.
Hi, Caitlin. This is Tyke. How are you doing?
Hi,
This
good. How
is
are you?
this is fabulous, obviously. You said that you were working towards a 2-week scheduling from the time the abnormal pap was detected to the colposcopy. So my question is, why the 2 weeks? Does the literature say that if you catch it in 2 weeks? As I think about the annual pap exam, I mean, it could be, this abnormality could happen a month later. So, why the 2 week? Is there something that says that from that first detection to 2 weeks is besides being obviously the optimal, right, reason for doing that?
Sure, that's a really great question. And so the literature was actually suggesting within a month. And so we actually decided on the 2-week time frame, so that if we were unable to meet that, we were still within what the literature is recommending and what the guidelines were recommending. So even if it was, 3 weeks out, we may not have hit our goal in that sense, but that was also an opportunity for us to look at and say, okay, maybe 2 weeks is not realistic. Maybe we need to make it 3 weeks. And part of looking at all of that, and trying to get those patients in, was also trying to figure out all of the factors that were stopping the scheduling too, right? And one of those is, do we have the result? Which is why I worded it 2 weeks after receiving the result versus 2 weeks after the PAP. Because for the most part, we got our PAPs fairly quickly in San Diego. For example, I could get a PAP back within, 72 hours, sometimes up to a week. Whereas in my current clinic, it takes 3 weeks for me to get the result. So obviously 2 weeks from having the PAP done is not appropriate. So it would definitely have to be from when we receive the result. That's when we can do the scheduling.
Thank you. And of course, that was my next question. Are you able to maintain these results, or are you able to meet the 2-week follow-up? Because I also think about women having jobs and families, and what did you look at the primary reason for not being able to schedule 2 weeks? Was it really an issue with your scheduler, or was it because patients took them maybe up to a month to find a date that they could come in that you were available?
So this was not part of the project, but as a side note, we did look into this just for our clinic so that we could fix it on our end if we could. And the majority of the reasons why the patients couldn't schedule was provider availability. So we decided to actually implement, apart from the project, in our scheduling template. Instead of just having procedure slots throughout the day, we had dedicated colposcopy slots. And in those colposcopy slots, that could be the patient scheduling for the consultation for the colposcopy, or it could be for the colposcopy itself. So once we opened that up, and this was after the implementation, but once we opened that up, we saw an influx of patients that were able to schedule.
Oops, excellent. And there's a question in the chat box from Dr. Olin. When you read it, Teresa says, wonderful information, Dr. Gross. Are the ages 18 years and older, or even younger patients? And is there ideas about testing children younger than 18?
Oh, that's a really great question. And that is what we looked at. So the reason I chose age 21 is because that's what the guidelines were for PAPs. And now if you have postcoital bleeding, so that bleeding after intercourse, you could potentially do a PAP even if they're age 16 or 17, right? Because we need to know why you have this abnormal bleeding on your cervix. So just to kind of fine tune and just make it very consistent, we chose age 21, knowing that the majority of the patients probably would be coming in with that abnormal result. So as I'm implementing now, if I ever did a PAP on a patient that is under 21 for whatever reason, then the criteria would be the same, right? I would document the same. I would make sure to educate them the same, schedule them the same. It would be the same, yeah. But as far as doing routine PAPs on patients under 21, that's not recommended currently.
Thank you.
Sure. And any other questions?
I just had a question out of curiosity. Is there an age, like an age where it stops? Like if it begins at 21, is there a certain age where women no longer do that?
Great question. And technically, yes. So guidelines right now are age 21 to 65. And that's where the research is, 21 to 65. But I still have patients that come in after age 65 for various reasons. Maybe they've had abnormal in the past, or they want to continue to get the PAP done. There's currently more research being done. I was at a conference, it was about a year ago. I was at a conference where a spokesperson from ASCCP, one of the researchers, was talking about that they were trying to extend that research within, or extend the age limit for the research. So currently 21 to 65 is what we see. And those are the guidelines that usually insurance likes to just stick with as far as coverage. But you can absolutely continue that. And hopefully that research will change, because cervical cancer does not discriminate on age. It doesn't just go away once you're 65. So I'm interested to see what that looks like in the future.
So of course, that leads me to my question, Caitlin. Is there an age range where you see cervical cancer more commonly than others? I mean, is it, do you see it primarily in 25 to 35? Do you see it, has that been determined?
Not officially. So just based off of my experience and some of the literature that I read while I was doing the literature review, that it was more in perimenopausal, postmenopausal age range. So kind of in the mid-ish 40s through up to age 60. That's the bulk of the patients that have been diagnosed. But I have seen, unfortunately, I diagnosed a 22-year-old with cervical cancer a couple years ago. I've also diagnosed a 75-year-old. So it's, or have found it, I should say, not on the colposcopy. So I would say kind of that perimenopausal, postmenopausal age range is more common.
And Dr. Bruce, I just had a question about, do you think that the prevalence has decreased due to the HPV vaccination?
Absolutely, yes. So vaccine for HPV, that I'm sure you've seen that the age has now extended. Before it was to age 26, and now it's extended to age 45. And so there's extensive research that is showing that even women in their 30s or 40s can still get this vaccine. We're seeing a decrease in those numbers. So absolutely.
And one other comment I had, I just wanted to see if you were utilizing this in your clinic, allowing women to collect the sample themselves.
Great question. No. Right off the bat, I'll say no. That's a newer technology that has just been approved. It wasn't approved during the time that I was doing the implementation. And so I did not include that. However, I'm looking into the research, and I know that there's extensive research. I have if I can just be completely honest here, I have a lot of concerns when it comes to self-collection. Are we truly getting, are we truly collecting cervical cells? Are we getting enough? Is it a good reading? And I know that there's research to back that up. I just am a little bit nervous, and maybe that's just, I'm kind of, I guess, old school in that sense that if I do it, I know I'm collecting from the cervix and I know I'm getting the cells that I need. But that would be interesting. Healthcare is all about changing and adapting to new technologies and things like that. So that is something that I've been working on personally, but something that will be interesting to see, that if we start implementing the self-testing, the self-swab, that are we catching abnormal results that way too?
I have a quick question.
Mhm.
Yes, is there any literature anywhere that has any information with regards to incidence or prevalence with cervical cancer with women who've had children versus those that don't have children, who've not had children?
Oh, that's a really great question. And I'll be honest, I did not really research that, but I'm going to write that down because that is something that I'd like to look into.
Thank you.
Yeah.
Dr. Bruce, I have a question. The recent literature, within the last 5 years or so, I've noticed that there is publications available about a high increase in STIs among women over age 65. That would be the baby boomer population, the free love generation in there, the 60. So anyway, I'd I've read some publications in geriatrics that talk about it suggests that there's an increased incidence of HPV in
Mhm.
older women who live in RV parks and mobile home parks.
Mhm.
Um, I'm just throwing that in as something to think about. But obviously, with the increase in infections, STIs, you would expect to see an increased incidence of HPV, perhaps a knowledge deficit among the older women in that particular population. And I'm wondering if you're aware of any studies that have been done related to STIs in women 65 and over.
Absolutely. So this is kind of a multifaceted question or answer to the question. Um, the incidence of STIs has grown astronomically in the older population, and the question is why, right? And so I definitely think that and what I've seen in some of the literature is the education aspect for sure. One thing to also consider is that there's a lot of insurances that don't like to cover STI testing or HPV testing for anyone over the age of 65. I personally have had to fight with insurances nonstop about that. And so I think that has an impact into the literature and into the available research, because if we're not testing for it, we don't know it's there, right? But now, because there's a huge influx, I think that we're starting to be able to test it. More insurances are being a little bit more lenient on that. So that's probably why we're seeing that boom. But absolutely, I definitely have seen research where STIs have increased in the older population, and we've seen HPV increase with that as well. And that's what ASCCP is researching right now. In the conference, they spoke about that they're looking to extend the age to 85 is what their research is going into right now. So I'm hopeful that we'll have even more answers to that.
Good, thank you for that. I'm really concerned about it because we have also in our generation now, or at the present time, we have a much longer lifespan, approximately 10 more years than we had, 20, 30 years ago. So this means that if women are being diagnosed with HPV at age 65, they could be developing invasive cancer, within 10 or less years of their lifespan, would increase costs, not to mention all the other disadvantages. But it seems to me that it would be a really important issue to bring forth to be advocates with our legislators.
Absolutely. I totally agree with you on everything that you just said. I feel that once you hit age 65 in a lot of different areas, and this is personal opinion, but I feel that we just kind of say, all right, good luck. And really, I mean, people are living longer, and we need to look at that in the literature, and we need to
Yeah.
expand our testing and expand our treatment and our care base. So absolutely.
I live in Southern California, and we, in a 55 plus community, we have a large number of women in their mid 80s who are working part-time or full-time and playing pickleball 3 times a week. So the
They're
quality
going.
quality of life has really changed through the decades.
Absolutely. Yeah. That's a really great point. Thank you so much for bringing that up.
Thank you.
Okay, well, thank you. If there are no more questions, just would like to thank Dr. Bruce.
Thank you.
Wonderful
Thank you so
job.
much.
Does anyone else have any comments or questions? Okay, great. Thank you so much, everyone.
Brilliant work. Thanks, Caitlin.
Thank you so much. Thanks everybody for coming.
Thank you.
Thank
Dr.
you.
Bruce. Bye.
Bye-bye.
Thank you. Great job, Caitlin.
Thank you so much.
Now I know what it is versus a colonoscopy.
I'm glad. Yay.
I'm telling you, when I was reading the thing before.